pressure reduction. And during my talk, just remember everything that Randy told you about the limitations of intracranial pressure monitoring and treatment. So, in the speaker disclosure, the opinions I express in this talk are those of mine alone and not those of my funder. So, before we get on to the Eurotherm trial, I think it's useful for me as well to go back and think, why do we think hypothermia might be a good thing to use to modulate brain swelling after trauma? Well, if you look in the literature, there are a huge number of anecdotal case reports of individuals who survived without a heartbeat for hours while submerged in frozen water or similar. Clearly, the message is that cooling the brain down protects it from a lack of cardiac output or oxygen substrate delivery. These are only anecdotal, but every meeting I go to where hypothermia is discussed, new cases like this are presented. Hypothermia was instrumental in the progression of cardiac surgery. We wouldn't do this now, but profound hypothermia allowed cardiac surgeons access to within the walls of the four chambers of the heart for the first time. So again, and with good quality survival afterwards. So the message is clear that at times of inadequate or no cerebral circulation, reducing the temperature of the brain protected it against this reduction in oxygen substrate delivery. So what about other models or animal models of brain injury? I don't have an equivalent for traumatic brain injury, but this is a systematic review that's conducted by the Camarades team in Edinburgh of stroke models treated with hypothermia. Each vertical line along the x-axis is an individual trial, and the longer the line, the wider the confidence intervals for the individual trial. Only better quality laboratory experiments are included in the Camarades systematic reviews. But you can see here, I think this is a percentage improvement in infarct volume, the first slide. This is an enormous treatment effect. There are very few neuroprotective pharmacological agents that are as effective as this in the laboratory. And you can see the effect is consistent across a huge number of individual laboratory experiments. And these were experiments that were properly randomized, blinded follow-up, etc. And if you look at improvement in neurobehavioral score, the same signal is there. Really hugely impressive treatment effect in stroke models, ischemic stroke models treated with hypothermia. And again, that effect that was seen in this systematic review was consistent and greater than most pharmacological neuroprotectants. So case reports, laboratory work, encouraging. And if you actually looked at the different species and different models of use for this ischemic stroke systematic review, the signal was consistent across all species and all models. So it's apparent that the hypothermia could benefit ischemic stroke irrespective of model used. We have Randy talking about the dose of raised intracranial pressure. Well, one of the things that we worry about is the dose and timing of hypothermia. But in the laboratory models, even delayed induction and maintenance of hypothermia was associated with a significant treatment effect, both in terms of neurobehavioral scores and infarct volume. So the laboratory work, very convincing. And in traumatic brain injury, for years we've considered that the final common pathway to these secondary injury processes is ischemic damage. So it wasn't difficult to think that hypothermia potentially beneficial following traumatic brain injury. So in Edinburgh, I managed to enlist 6 medical students to help me update the systematic review of therapeutic hypothermia in adults following traumatic brain injury. Now these clinical trials, there were 18 trials reporting functional recovery and 20 trials reporting mortality. These trials were all of early hypothermia for neuroprotection. Because I got medical students involved, they entered the data the wrong way round, and this goes against convention. Nonetheless, I published in this format, but the convention would normally be that the summary estimate of effect would be on the left-hand side of the line of unity if it favoured the new intervention. What this says up here is there were more poor outcome patients with normothermia in the control arm. In our systematic review, we differed from the Cochrane collaboration systematic review. We excluded paediatric studies because we thought the physiology is different, body surface area to weight ratio is different. So these were only adult studies. And we also included in our primary analysis some of the Chinese studies that Cochrane had rejected. We included them if there was no good reason for rejecting them. Some of the communication from the primary author was less than clear, and we did a subsequent sensitivity analysis taking any paper that we had some doubt about the quality and risk of bias. But the signal and the treatment effect is all in the same direction, just with slightly wider confidence intervals. So again, encouraging us that there might be neuroprotection from cooling the brain down. Longer than I care to think ago, the European Society of Intensive Care Medicine conducted a Delphi exercise. Now, the European Society of Intensive Care Medicine was generally considered to be a respiratory failure society, but they conducted a Delphi exercise asking their membership what research question would the membership like the society to fund a trial to answer. And to my amazement and delight, the primary question was, does intracranial pressure monitoring and management improve outcome? So we considered many different trial designs, but in the end we felt that the cleanest was a study testing a particular intervention. Well, if you remember my slides from earlier this afternoon, we looked at hypertonic treatments, we looked at barbiturate therapy, and we looked at hyperventilation. But the trials were small. The summary estimates of effect did not encourage us to investigate them further. And in fact, I don't think the funding agency would support clinical trial on those particular interventions based on the publicly available data. However, hypothermia, there were considerably more data, our systematic review, and that was sufficient to convince the society to fund the pilot phase of the study. There were a new funder to trials, and that was a challenge in itself for us. Following pilot phase, we went on to NIHR funding, which considerably more stable and slightly less problematic to deal with funding. Our initial power calculation, we thought we needed 1,800 patients, and that was to allow for some of this heterogeneity of head injury population. But after the pilot phase, what we discovered is that patients who had acute subdural hematoma or contusional head injury were the ones that got raised intracranial pressure. Almost 80% of our pilot phase patients fell into this category, and for the main phase of the trial, we saw a similar effect. Because of that, we felt that this reduction in heterogeneity and, in truth, an aspect of practicality reduced the target recruitment down to 600. So I've stripped off the inclusion-exclusion criteria. The data are already published and available online in the New England Journal. But the key to understanding our study are the sort of 3 stages of intracranial pressure management. So basically, this is the Andaluvian single-track hammer and nail approach to raise intracranial pressure. Patients were screened if they were admitted to the intensive care unit with diagnosis of traumatic brain injury. They had intracranial pressure monitoring in situ. We screened almost 2,500 patients to recruit 400, with 85% of our patients not having an index event of ICP above 25 millimeters of mercury, despite simple stage 1 measures. The stage 1 measures were just sedation, make sure the patient was synchronous with mechanical ventilation, head up, CSF drainage, if that's what you did in your centre. So these were not complex interventions, but I think a key message for us was that modern critical care management, probably better pre-ICU, pre-hospital resuscitation and prevention of hypoxia, hypotension, resulted in very few patients developing brain swelling in 8 months in the ICU. However, if they did have this index event, ICP above 20, for at least 5 minutes, and having corrected all the remedial sort of stage 1 therapies, then patients could be randomized. They were randomized to a control group, and that meant the centre, they were all experienced centres, they could do whatever they would normally do. That generally meant hypertonic therapies. Barbiturates were excluded at this stage, although they could be used as a stage 3 option. In the treatment group or hypothermia arm, patients had induction of hypothermia and maintenance of hypothermia as the primary intervention to reduce intracranial pressure back to below 20 millimeters of mercury. Our target temperature was the range 32 to 35 degrees centigrade. And the reason we chose a range of temperatures is that we felt that we wanted to get a better balance between the dose of hypothermia treatment and the severity of injury, such that patients who had higher or more intractable raised intracranial pressure would wind up having hypothermia down to 32 degrees and for longer. However, if you had a transient episode of ICP above 20, settled down with hypothermia to 35, the patient would wind up having modest hypothermia to 35 for 48 hours with rewarming. So we thought we had a better balancing against the biomarker for the injury process. If hypothermia to 32 failed to reduce intracranial pressure, then other stage 2 treatments were available to the centres. And they were allowed to use their multimodal monitoring, whatever, we have copies of all the protocols, whatever they would normally do to manage raised intracranial pressure. If this all failed, then stage 3 options were available, and these included decompressive neurosurgery of some description, decompressive craniectomy if they wanted to do that, and we collected outcomes at 28 days death of discharge, which was the modified Oxford Handicap Scale, that had previously been rebranded by Ian Roberts as HIRIOS, or the Head Injury Related Outcome Scale. Basically, it's a very simple functional assessment on a 5-point scale. And we did this because we were very worried with our international recruitment that we would have a serious problem with loss to follow-up. Our most rapidly recruiting non-UK and European centre country was in Delhi, in India, and we were concerned about potential loss to follow-up there. Our primary endpoint was the extended Glasgow outcome scales collected at 6 months. In the UK, we sent out written questionnaires, and if they weren't returned, then we made a telephone call, having previously checked with the family doctor that the patient was still alive. In the end, we had 98.5% follow-up on our primary endpoint, and that's down to the efforts of my postdoc, Richard Harris. So that's the design of the study. So the baseline characteristics, it's absolutely typical of head injury population. The trial was, as I'm sure many of you will know, was stopped early. We were stopped after recruitment of 386 patients. We didn't quite make it to the largest hypothermia and head injury study. So these are the baseline characteristics of the 386. One of the patients withdrew consent for follow-up, so the analysis of our intention to treat analysis is for 386 patients. There were no differences between the two groups, so our randomization, minimization with the random element was successful. One of the things that we didn't stratify for in the trial was the number or any pre-randomization neurosurgery or even multiple neurosurgeries. And the journal specifically asked us to go and look at this, but by chance and good fortune, there were no differences between the two groups in single or multiple neurosurgeries. So did we actually do the experiment we set out to? Well, this is probably for me was the biggest surprise of the lot, these data. Not because the intervention arm, hypothermia group, got hypothermia. Now this is the average of the average daily temperatures, but because of the sort of standard care group, you can see here the average of the average daily temperatures, clearly the clinicians, and they were not mandated to target any particular temperature, thought that 37 degrees was what we should be aiming for. Intracranial pressure, no statistical difference between the two groups, broadly similar across the 7 days following randomization. However, ICP was less problematic in the hypothermia group. There's significantly more patients in the standard care arm of barbiturate infusions, particularly during days 1 to 4. So, although the absolute numeric value is similar between the two groups, the therapeutic intensity was significantly greater in the standard care arm. So they got more hypertonic treatments, they got more barbiturates, they got more surgeries. No difference in mean arterial pressure between the two groups. There's a slight separation on day 1 and 2, with mean arterial pressure slightly higher in the hypothermia arm, and that's reflected in cerebral perfusion pressure, which was not significantly different, but slightly higher in the hypothermia arm. So this is the punchline. At our primary endpoint in intensity analysis, there was significantly more deaths. The hazard ratio was 0.047 for mortality, and that's unadjusted. In our adjusted primary endpoint of the Glasgow extended Glasgow outcome scale, again significantly worse in the hypothermia arm. We thought that one of the reasons that this might have occurred was due to new pneumonias or sepsis in the hypothermia arm, but there were no difference in new pneumonias between the two groups. So the conclusion was that the titrated hypothermia was pretty effective at reducing intracranial pressure, in addition to standard care, but didn't improve outcomes. So should we have been surprised? Well, our study was different from all previous hypothermia studies in traumatic brain injury, in that we were titrating the dose of hypothermia to a biomarker of injury severity, but the outcome was worse. So we remain somewhat unclear whether this is a biological effect of hypothermia or something to do with the imbalance in co-interventions. A contemporary study published during the Eurotherm trial is the BiHypo study from Japan, where they looked at prolonged mild hypothermia compared to targeted temperature and normothermia, and this trial was stopped early for futility. So that's another example of a study where the control group got managed targeted temperature management to normothermia, intervention arm to hypothermia, no difference. What about cardiac arrest as another disease process where hypothermia has been used? Well, when the control group is managed to normothermia, 36 or 37 degrees, there is no difference between the two groups in terms of outcomes. So hypothermia showed no benefit over normothermia. In pediatric cardiac arrest, and I'm sure many of you are familiar with the targeted temperature management study from Nicholas Nielsen, where patients were managed to either 36 or 33 degrees centigrade. It's caused a huge amount of debate in post-cardiac arrest management. No difference between 36 and 33. And that contrasted very strongly with the HACA trial published in the early 2000s, where patients were managed to hypothermia against no targeted temperature management in the control group. Under those circumstances, hypothermia showed benefit. I think this is a recurring theme, that as far as I'm aware, there is no study that showed benefit from hypothermia when compared to targeted temperature management and normothermia in the control group. So no difference in survival. So is hypothermia, I think the question I was asked is hypothermia dead for intracranial pressure management? Well, there is one group that hypothermia does appear to be effective, and that's neonates. My own opinion is that they are a somewhat different species than adults. Possibly, I don't want to offend anybody, but possibly much closer to the laboratory preparations that were studied in the stroke models that I presented earlier. They have immature thermoregulatory mechanisms. They have a much reduced body surface area to weight ratio. It's very easy to cool a neonate. But I think the data there is compelling. Now this is something that's dear to my heart. In Edinburgh we're trying to develop, we don't call it selective head cooling, because I think that's absolutely impossible. Blood flow to the brain is enormous, 20% plus in your cardiac output. If you are effective at cooling down brain parenchyma, because of the high volume of blood going through it, it's very difficult to do it. But if you're successful, you will see a reduction in core temperature. And in fact, many direct brain cooling studies, included in this comment, have used an esophageal temperature reduction as evidence of direct brain cooling. But it's potentially something for the future. I think they use the Olympic Cool Cap as a particular device for brain cooling, this neonatal study. If you looked at the global population investigated, the signal was disappointing, but when you looked at different subgroups of EEG analysis, it was clear that there are subgroups of the neonates who clearly benefited from hypothermia. My interpretation is with a sort of salvageable type EEG trace. So, have we made any progress in understanding hypothermia? Well, that's the problem when you do a clinical trial. It all seemed quite straightforward and clear at the start. You conducted a trial, and again, I keep complaining the UK's cash strapped. We ran a clinical trial on £2 million. That's what, $3 million, compared to the Cool Kids trial, which I think got $22 million. So we had to do things to allow us to conduct the trial. One of them was we made it pragmatic. So we tried to keep data collection, the burden of data collection, to a minimum. And that's really good. We recruited well, and unfortunately, when you get a result that's surprising, having a lean data set makes it quite difficult to go back and work out why you got that signal. It's all very well when you get an expected result. When it's unexpected, then interpretation requires additional data. So I'm delighted that more than half of the centres involved in the Eurotherm study are undergoing an absolutely mammoth additional data collection exercise to try and see where there were differences, particularly in core interventions. So we made progress on technology. Now you can try and guess where these implements were placed to cool the poor patient. We've certainly made a lot of progress on those devices, and I think you can go and see the devices in the exhibition stand. But my conclusion has got to be that there is not enough evidence to make a strong case for targeted temperature management that aims for hypothermia to protect the brain following traumatic brain injury. I'm just going to follow up this conclusion, because I see I've got a couple of minutes left, to say that we've conducted a number of post hoc analyses, but our data monitoring committee said to us that they were asking for reports every 3 months, and the data monitoring committee asks you to do that, then you know something's amiss. And one of the reports they asked for was for us to look at the predicted chance of death or poor outcome for each patient that we had recruited. Now, there are many predictive models for head injury, but we used the impact extended model, so we felt it best reflected the sort of Northern European type patient cohort that we'd recruited. So every single patient was assigned a predicted mortality. Now that ranged from less than 10% up to almost 50% for some of the patients. What we did then was we just divided them into 3 tertiles, so 3 equal groups. So there's the same number of patients in each group, and we called one a lower risk of death and poor outcome, a mid risk, and a high risk of poor outcome. Now these data are not yet published, but are prepared and ready for submission. And what we found was that if the high-risk population, and these were patients with on average 45% chance of mortality, so very severe head injury. Hypothermia had no effect on their outcome. There was no difference between control and hypothermia. We looked at the mid-risk group, so that was a predicted mortality of almost 20%. I don't know if you use the online calculators in speaking to families, but 20% still severely injured group. Hypothermia, no effect. So the entire signal in the Eurotherm study came from the low risk of death and poor outcome group, which means makes the additional data collection even more important to us. Low risk of death following and poor outcome following head injury is dominated by one factor, and that's age. So these were the youngest patients we recruited. I'm still unfortunately unable to tell you whether it's a biological effect of hypothermia or an imbalance in co-interventions or some complication of hypothermia and its associated co-interventions. So anyway, thank you very much for your attention.